Hello, everyone. Welcome back to the Migraine Mentors Minicast. My name is Dr. Thompson Maesaka. I'll be riding solo today. Dr. Eric is on daddy duty. So, yeah, let's nerd out. If you are new, welcome. If you are returning, thank you so much for continuing to come on this ride with us. We're just eclipsed. I think this is our 58th consecutive episode without missing a week. So, we're settled into a groove here, and we really hope you guys are enjoying the content. We're doing our best to make sure that it's valuable and useful to you, so thanks for continuing to come back. So what we're going to talk about today is the difference between migraine with aura and migraine without aura, and really going to dig into how headaches are classified and diagnosed, and why a lot of people, even probably listening right now, have probably been misdiagnosed maybe a couple times. And we'll dig into why that is. The diagnostic criteria can get pretty sketchy sometimes. We'll go into the nitty-gritty of that. So if you're listening and you get migraines, chances are you or someone you know has had a migraine with an aura. So when we describe an aura, I often describe it with patients as this indiscriminate sense that it's coming. Some collection of weird symptoms that let you know your whole world is just going to get turned into shit, pardon my French, in a bit. It's like 10 to 60 minutes before the actual head pain starts, and every person I've ever talked to has their own unique collection. So some people get really thirsty. Some people will start to yawn a lot. I've had some people crave really salty foods. Even had one person I went to school with. She would have these auditory hallucinations of like heavy metal drums, which is the most terrifying way your brain could let you know you're about to have the worst day ever. I would always, when she wasn't having a migraine, would just kind of laugh and make jokes about it. It's like, I don't know what you did in a previous lifetime for that to be your aura, but that is just cruel and unusual. So 10 to 60 minutes, a lot of people will have the visual aura, which is sometimes referred to as a scotoma. It's a little sort of sparkly dot in the center of your vision that expands out to the periphery. That's what I get. I get something called ocular migraines, where it's really the only symptom I get. And then it just goes away and I feel like I have a hangover. But then other people typically will cascade into a much more nasty collection of symptoms. The aura migraines are about 25 to 30% of people with migraines, so not quite as common. It also predisposes you to other conditions because of the physiology of why that happens. People with aura typically tend to have other forms of vascular issues later on in life, whether that be TIAs, transient ischemic attacks. There's some research that supports that it's somewhat linked to strokes later in life. That's usually when you go into super chronic land. Migraine without aura is much more common and much more cruel in my mind. At least if you have an aura, it gives you time to sort of weather the storm. It gives you a chance to go to somewhere that's quiet and dark. And 75, roughly, about 3/4 of people do not have an aura. So these migraines just kind of pop out of nowhere. There's no pre-headache neurologic symptoms at all. They kind of just come out of nowhere like a ghost out of the closet and just completely wreck your day, which I think is also kind of cruel, maybe even more cruel than the heavy metal drum aura. So when we dig into the diagnostic criteria, that's when it starts to get kind of interesting, because we've talked about it in previous episodes. Migraine is one of the most misdiagnosed conditions out there. I believe the last research paper I've read around it says that over 50% are misdiagnosed, and it's because of these diagnostic criteria. So if we look at migraine without aura, headaches that last 4 to 72 hours, which are untreated or unsuccessfully treated. And you have to have two of the following conditions. So unilateral location, which just means one side of your head hurts. It pulses. It is moderate to severely intense, and it is aggravated by physical activity. And then during the headache, there is at least one of the following: nausea, vomiting, sensitivity to light and sound. And so if I think back to just being a headache specialist, I can think of 2 or 3 other types of headaches that mimic this almost exactly. One of them is called a cervicogenic headache. So it just means a headache that comes from your neck. If you're watching the video, I am pointing to the top of my neck and tracing up over my ear and kind of poking myself in the eye. That is a traditional path of a cervicogenic headache. So that fits one of the criteria. It's unilateral. Sometimes it can be so intense that it pulses, or you sort of, it raises your blood pressure to the point when you can sort of hear your heart beating in your ears. That would automatically meet 2 of those criteria. And if it was that intense, it would also meet the third one, moderate to severe pain intensity. And, usually if you're in that much pain, you don't want to move around. So straight away, one of the most common types of headaches that we see very commonly misdiagnosed is just that, cervicogenic headaches. And these are the headaches that make you look like a total boss in the clinic. This is where you do one thing and it takes it away completely, and they think you're a genius, when really they were just misdiagnosed, or this neck component is also contributing to a larger migraine diagnosis. When you move into aura, well, before we go there, there's also, I think back to my college days. I've had hangovers that are exactly like this. I actually thought one time that I had a migraine. I told this story before. I used to think migraines were different, and I was like, oh, I just have this terrible migraine today. I can't go to class. When in actuality, it was just misdiagnosing myself. So it's just one of several. We'll move on, but there are at least 3 others that I've seen clinically that can present like this. Post-traumatic headache is one of them. Some people will have these left and right brain deficiencies from head trauma that affect the blood flow to one side of the face, which can definitely make it look like a migraine. These things called trigeminal autonomic cephalgias, big words. My point is there's a lot of headaches that look like migraines, and that's why they get misdiagnosed a lot. And then when we dig into the migraine with aura, that's when it's at least 2 attacks fulfilling the following criteria. So 1 or more of the fully reversible aura symptoms. So you can have visual symptoms, sensory symptoms, that's when you start to almost feel like you might be having a stroke. Hemiplegic migraines are often mischaracterized as strokes because of these sensory symptoms. Speech and language, as I stumble over my words, can create what's called aphasia. So when you can't find words and you find it very difficult to speak. Motor deficiencies, a lot of people will get really sluggish movement, or they sort of lose the ability to walk straight. Brainstem symptoms, which vertigo, tinnitus, things like that, and then the retinal. So you have these weird changes in your vision. And then the rest of it is relatively similar to the migraine without aura. And so when you look at it this way, I mean, I've even had some patients come in and we break this down together, and they realize that they're not having migraines at all. And we sort of break them out of this paradigm and introduce them to the actual type that they're having and the treatments that work for that. And so that's really what this episode is about, is sort of challenging your paradigms maybe a little bit, and hopefully at the very least just opening you up to the idea that you might have other headaches that are sort of driving the migraine. We won't go super into it today, but the bucket theory that we talk about, there's sort of underlying other causes that are stressing the system that cause it to then trigger a migraine. So some of these secondary headache conditions can be perpetuating the actual migraine itself, which is, of course, as we know, a larger neurologic event and not just a headache. So I'd be really curious if you're listening out there, just Google migraine diagnostic criteria. Just look through them. And then if you start to get curious as to what other headaches you might have, look up tension headaches, cervicogenic headaches, post-traumatic headaches, even look up something called autonomic cephalgias. Those are really challenging to diagnose as well. So yeah, this episode mostly is about just doing some homework and some research yourself. And I think when you look into the diagnostics, I think you'll realize really quickly why these things go misdiagnosed so frequently and why it's so frustrating to have them. So my name is Dr. Maesaka. Genuinely want to thank anyone that's listening for being here. Like I said, Dr. Reese and I love to make this content for you guys. We just genuinely hope it's helpful. We're always looking for feedback. Last episode, we had asked you for it. So if you have anything you'd like to hear more about, any topics you'd like us to cover in depth, we are at your service, you guys. We are only doing this because we keep getting messages that's saying thank you and it helps. So as long as that's the case, we're going to keep showing up. So if you're a first-time listener, thank you for showing up. Make sure to subscribe down below. And if you are a returning listener, thank you so much. We will see you next week. And please let us know if there's something you'd like to hear about. Take care, guys.